Hi everyone, welcome to our final work experience session. I'm Shruti, one of the regional leads at Medics&Me and also a second year medical student. So thank you very much for taking the time to join us. Today we're also joined by Ms. Sonali Kaushik, who has very kindly given up her time to be with us. Ms. Kaushik is a gynaecological oncology surgeon at the Royal County Sussex Hospital in Brighton, and she's currently a training program lead for subspecialty training in gynaecological oncology at Brighton, and also the honorary clinical senior lecturer at BSMS. So loads of incredible things. Thank you very much for joining us today, Ms. Kaushik, and we're very, very grateful to have you today with us. Before we can begin, can everyone quickly just put their unique identifier number into the chat for a short attendance check? And just to give you a brief outline, the way the session's going to run, as always, we're going to have a quick talk, and then the second half is going to be will be based on interview practice questions. So without further ado, I'll hand over to you, Ms. Kaushik.
Thanks, Shruti. Thanks for that introduction. Hello, everyone. Just to get going, a bit of music, which is one of my favorite soundtracks. So I'm just going to talk about gynaecology and a bit of obstetrics and gynecology, and how things work in terms of training. So this is me. I think I was around about 7 years old. It's my father in the middle. He's a cardiologist, and that's when he got his membership. And I think it was around about that time that I decided that I wanted to be a doctor. So such is life. And I'm Indian, and my parents, when I was a teenager, decided to emigrate back to India. So I went to Delhi, and so I finished school in Delhi and then went to med school in India, which was good fun. But then I wanted to, I think because my father trained in this country and encouraged me to go and get some structured training in obs and gynae, I decided to come back to the UK. And I've been here since. So the way that it works, for one who wants to become a consultant in obstetrics and gynecology, obviously have to finish med school. And it's at least 2 years as a foundation doctor. So some of the F1s will spend time with us in gynaecology for a quarter of the year. And then we have F2 doctors that work in general obs and gynae, and learn some basic skills. But I guess once in your foundation training, you've decided to become an obstetrician gynecologist, you would apply, and then it is a 7-year run-through program, which is good. So essentially, ST1 and ST2 are spent as a tier 1 doctor or an SHO, and then the rest of the 5 years you're basically honing your skills in obstetrics and gynecology, and potentially deciding on whether you want to do subspecialty training or not. So as far as exams go, one has to pass one's part 1 MRCOG around about ST3 level, and then at ST5 complete membership exams, and then perhaps continue to train in general obstetrics and gynecology, or one might decide to spend some time doing reproductive medicine or fetal maternal medicine or urogynecology or gynaecology, like I did. And so I started my obs and gynae training as a South Thames Deanery trainee in 2005. And at that time, it was all of South London and caesarean Sussex. So it was quite a large region to train in. And at that time, my son was about 3.5 years old. So there you go, it's possible. The first thing you do is learn how to do a caesarean section. And there you go, that's when you sort of start establishing your basic obs and gynae skills. I have to say, we don't smack babies on the buttocks anymore. So after I finished my basic obs and gynae training, got my membership, I think all my mentors encouraged me to train as a gynae oncologist. And I think looking back, all throughout my training, I worked on teams that were treating patients with a gynecological cancer, and it was fulfilling and it was inspiring work, and so you want to emulate your bosses and people that have trained you. So it's a 3-year training program, and you end up spending time in colorectal surgery, neurology, oncology, palliative care. And it's a very holistic training program where you understand all aspects of cancer care for women with gynecological cancer. And during that time, I also completed my research from the University of Bristol. And my research was database research. So I looked at the records of about 88,000 patients with gynecological cancer to try and understand the factors that impacted on their place of death. And so it was research is important. In order to understand how to interpret and critically analyze data. The expectation is that you spend some time doing research, and it does set you up for the rest of your sort of professional life. So I'd highly recommend thinking about research. This is my team. So these are my colleagues and these are the people I work with. And that's why I enjoy going to work, is because the good thing about medicine is that we work in teams. So there's the emotional support. You get advice, we bounce ideas off each other, we work together, we operate together. And the goal is to improve outcomes as far as cancer care is concerned for women in the department. So 2 of my consultant colleagues, some of our F1s who were there at the time, Caroline, who's our CNS in the middle, and one of our registrars. And, this is what we do. So we take out large ovarian masses, we put plans in place based on their imaging. And ovarian cancer, certainly as you can see in the photographs here, ovarian cancer is a surface disease. So disease spreads from the ovaries or from the fallopian tubes onto other organs. It involves a variety of surgical skills to be able to excise this disease. And that's why it's good to collaborate with colleagues and work in teams, so you're not alone when you're treating these complex patients. And I was talking about research earlier, and this is just an example. So these are Kaplan-Meier charts, and Kaplan-Meier charts look at the duration, so how far do patients get in terms of survival. And these are 2 studies that I put up next to one another. And it's really a description of how cancer care has evolved. So on the left side, you'll see a trial called the CHORUS study, and this was a UK or a British study. And basically this looked at patients with advanced ovarian cancer who were probably treated in the early 2000s, so 2004, 2005, 2006. And at that time in the UK, patients would have a hysterectomy, they had to have the tubes and ovaries out, and perhaps a little bit of disease taken out at the time, so in the omentum, or perhaps some lymph nodes. The average operating time was about 2 hours. And so patients had a disease-free interval of about 11 months. And their overall survival, was around about less than 2 years. So we weren't doing very well from a surgical point of view for patients with advanced cancer. And then a decade later, the LION study was set up, and this was a maximal effort upfront surgery where radical procedures were performed as part of treating patients with ovarian cancer. And these concepts have been flying about for about 20 years, but it's really difficult to put things into practice without an evidence base. So this was a study that was performed in Europe around about 2015, was published in 2017. And here the average operating time was 4 to 6 hours. Patients had bowel surgery, had diaphragm stripped, had spleens taken out, and you can see that there's an impressive improvement in the disease-free interval. So it was patients were doing very well for about over 2 years before the disease came back, and patients were living well beyond 5 years. And I was lucky because that was the time that I was sort of completing my training. So I was trained with that philosophy of maximal effort surgery, and spending time operating on these patients to get all their cancer out so that you could help improve their survival. And so this is early on. This is one of my patients, young patients. So we strip the diaphragm, and you can see there's a big lump of disease on the diaphragm. So that's stripping of the diaphragm on the right hand side. We took a bit of their bowel out with their womb tubes and ovaries, and the spleen came out as well. So a young 40-year-old who had fairly aggressive surgery to get her cancer out. And these are the type of operations that we do almost 3 times a week. As I said, research is really important, and one of my research interests is looking at the impact of stress on ovarian cancer recurrence, and my fellow Sarah Barron is doing her MD on this. And these are immunofluorescence studies where we looked at blocking the growth receptor on cancer cells, and we saw that if we use this drug and block the growth receptor, we could essentially stop those cancer cells from growing. And that's what stress does. Stress encourages these growth receptors on the cancer cells to encourage more growth. Sarah's going to publish this research very soon. So it's exciting times. We all know that obesity is a huge problem, and even though there are drugs like Ozempic and Wegovy, there is still a significant amount of obesity in the United Kingdom, and this is a patient with a BMI of 50. And this is this is a photograph that we took maybe about 7 years ago, and that's my colleague, Florian Drews. And at that time, performing laparoscopic procedures on really large patients was really exhausting. I'm only 5'4", and I have to stand on a step to be able to operate on these patients. So this is before we got the robot. And what we were doing is teaming up. So it was 2 consultant surgeons operating on patients to try and get the best possible outcome. So a really good example of teamwork. And we looked at our outcomes. So in the patients that we did operate on, we could see that their length of stay was much shorter if we were operating together. So that's the buddy operating. In the turquoise, you can see in each of the charts, everything is better. So a lot less blood loss, a lot less operating time, reduced length of stay, and therefore their overall anesthetic is also reduced. And so that was one of the things that I came up with a few years ago. Of course, now we're using the robot, and so it's much easier to sit and operate. So the other thing that we're doing is sentinel lymph nodes, and sentinel lymph nodes is when you inject dye into the organ to try and identify the main draining lymph node, which means that you don't have to take tons of lymph nodes out. So it makes your surgery a lot swifter. So the understanding is that every organ will have a main draining lymph node. And if you remove that lymph node and look at it under the microscope, and that lymph node is negative for cancer, then you can be fairly confident that that cancer hasn't spread. The trick, of course, is identifying that main draining lymph node. So now we have this really snazzy ICG dye, which if you shine an infrared light, either with a special laparoscope or using the robotic technology, you can identify these main central lymph nodes and remove them. So it reduces your operating time and also reduces the duration of surgery and the risk of complications to the patient. So we're really proud that we sort of got this kit and established that. During COVID, what we tried to do was keep ourselves employed. We were operating, but a friend of mine is a beauty therapist, and she diagnosed a patient with a melanoma of the vulva. And whilst she was waxing this patient, she saw this lesion, was really concerned, and told the lady to go and see her GP, who then promptly referred her in. And it's really difficult for women to self-examine. So a group of beauty therapists asked us to do some online teaching during COVID. And so we set up this below the belt sort of idea of sort of teaching beauty therapists about the skin of the vulva, so that if they looked at a lesion and they were concerned, they had the knowledge, or a little bit of knowledge, to encourage patients to go and see their GP. But also, if patients were concerned about a little lump down there, they could reassure them and say, well, actually, that's just a blocked gland, don't worry about it. I've seen lots of pictures because a gynecologist has shown me some pictures. So we really enjoyed that. We did 2 or 3 teaching sessions, and we had 60 beauty therapists that worked in Sussex join us for an online teaching program. So that was a bit of fun and felt like a good thing to do. So it's so many things that you can do as a doctor. There are also times where you have to remind yourself to slow down. And I do love my job, but yes, I think it's really important to carve time out with family and friends and take holidays and try not to sort of get overworked, because there's always something to do, or there's always a new initiative. And so there is time to do things, and you should take time out to do things that you love doing, whether it's cycling or sailing or things like that. So get out. So over the years, I've been a consultant now for 12, and I started training in 1999, and I think it's really important to practice humility. You're only as good as your last case, and I think it's really important to remember that, to not let ego get in the way, because I think a little bit of ego is good, and it's really important to have that confidence that one is competent, but a little bit too much, and that's, I think, when people get themselves into trouble. I think it's also important to remember that when you look at people and they're operating beautifully, those are technical skills that have been acquired through practice learning. So it's about going through the process, and whatever you want to do, if you practice it enough, you can stand out. None of us were born with these skills, and so please don't let it scare you when people talk about stuff. Everybody gets their time, and everybody's put their effort in, and that's how they've got to where they are. I think teamwork, I've demonstrated, it's really important, whether you're operating with people or doing research. It's really hard to do it by yourself, and we're lucky that certainly in the NHS we work in a system where teamwork and being a good team player, those are the main characteristics. A lot can be done, by 5 people. One person will take much longer to achieve what they want to achieve. And I think it's really important to embrace innovation, so as to have that open mind. And certainly when I was training, we went from open surgery and then learning laparoscopic surgery. That was really cool in 2006, 2007. And doing laparoscopic hysterectomies. And then I started my robotic training 2 years ago. I've now done 100 robotic cases, and I love that as well. And I really enjoy it. I enjoy my day in theatre on the robot. And for those of you who haven't seen the robot in action, there's a little video here. So you'll see the arms of the robot move. So this is a robotic hysterectomy for endometrial cancer. You see everyone sitting in theatre, it's all quite chilled. And then you can see the operation on the screen. So that's me. I'm sort of dividing the gonadal vessels that travel to the left tube and ovary. And I think this was my 4th or 5th case. And that's me there, sitting in a corner and operating. And so it doesn't really matter what the patient's BMI is. And it's, you know, it's a bit like flying a helicopter. It's good fun. Only you're obviously in theatre, not going anywhere. You know, there's always a way. You know, I think, you know, there's a way of getting that research post. There's a way of, you know, being the person you want to be, and sometimes you have to be a little bit patient. And there are always challenges. Life is a challenge, and sometimes things are easy, and sometimes, yeah, you know, just have to make do with the best that you've got. But you know, onwards and upwards, that's what I always say. I say that to all my patients. We need to move forward. So some tips. I think it's good to try and find a supportive mentor. And if you can find someone who's happy to share their journey, I think that's sort of priceless. I think if you are wanting to achieve whatever it is, I think preparation is key, and it's certainly for those people who want to learn to operate. I do tell them that go and practice your knots, because if you can't tie a knot, a blood vessel is bleeding, then you know, those are the basics. People will not let you operate. So understanding the steps of the procedure. So there's a little bit of work that needs to go into the background. And I think it's important to have a good work ethic, you know, pitching up on time, punctuality is important, and then seeing things through. So, you know, it's not starting something and then not finishing it is, it becomes tricky. Not all of us will finish everything that we start, but I think in terms of just getting your basics lined up, I think it's good to have a good work ethic. I always go back to this chart because I really do like it. And it's about sort of pushing yourself. So we all love our comfort zone. You feel safe and cocooned. And, you know, once you put yourself in that fear zone because you want to learn, there are times where you know, everyone finds excuses, or someone will try and drag you down and say, oh no, I don't think this is going to happen. It's going to be so difficult. But you have to push past all those negatives. And the minute you do that and start sort of dealing with those challenges, that's when you grow. And I mean, sometimes it isn't always successful, and you know, you have to go take a step back and say, okay, I'm going to head in a different direction. But yes, if you want to find purpose and live your dreams, then you have to grow. So you have to go through all those phases of, you know, getting out of your comfort zone and being a bit scared at times. So that's important. We do need more women in surgery, so less than 1 in 5 surgeons are female, and I think the environment needs to change. But the rotations have improved. When I was a house officer, you kind of started on a Friday, and I know you should never start a sentence with "when I was," but you know, times have got much better, and people can train part-time, and people take a year off maternity leave, and you know, there are nurseries set up in hospitals, and you know, I think it's you know, you want to work with good people, and there are certain parts of one's life where you need to take time off for personal reasons, and that's absolutely fine. It is encouraged. And so these are the people I work with, some theatre team, my colleagues, and this was one of our days. You can see some all-girl team, the girls on the wards. These guys are fantastic. They look after our patients. they call us when we're worried. I don't worry about my patients overnight because I know these guys are on it. And this is the MDT team, so all my consultant colleagues, oncologists, pathologists, radiologists, and a whole load of other people. So yeah, it's all good fun. Thank you.
Thank you so much, Ms. Kaushik. That was such an insightful session. I think everyone here would agree that it was incredibly helpful. And there's so much to gynecological oncology that is genuinely so amazing. So we really, really appreciate that you taking the time to join us today and share your experience. And thank you again for joining us. And I think we'll let you go back to your evening.
Delighted. Well, good luck, everyone. Cheers. Bye for now. Bye.
Bye. Everybody else, we will be moving on to the breakout rooms, and those will be generated very shortly.